after fall. He's an oral tobacco chewer and an occasional drinker. These were the X-rays that we had when he presented. We can clearly see this is a complete articular fracture of the distal end radius, extending to the volar lip, but there is no subluxation of the carpus. So he had this fracture on his dominant hand, that is his right hand. It was a complete articular fracture, and the AO OTA type was C3.2. A volar plating of the distal radius was planned for him. I personally use the trans FCR approach every time when I do a distal end radius plating. Now, to me, there are two very distinct advantages for that. I can utilize the volar ulnar corner better, and as you can see in the X-ray, there was a comminuted fracture of the complete articular surface of the complete articular surface of the distal radius. So that would have, I considered that FCR approach would be better for me to get the approach to the volar ulnar corner. And also it is away from the radial artery. But there is one potential disadvantage is the palmar cutaneous branch of the medial nerve is at danger during this approach. But that can very well be prevented by staying just radial to the FCR and never quite going ulnarwards. Now, this is the intra-C-arm picture that I have. We reduce the fracture with traction and extension over kidney tray. Articular surface had to be manipulated. I went through the fracture site and then just disimpacted the articular surface and achieved articular reduction to the best of my ability. But what I had to do but I had to place my plate well above the watershed line of the distal radius, because had I not done that, I would not have been able to buttress the comminuted fragments there. Had it been one single fragment, one single very distal fragment, I would have put two K wires and buried them under the plate. But then this being a very comminuted fracture, even that wasn't an option. So I really had to use a volar rim plate and keep it very, very, very distal, much distal to the watershed line. But one thing I make a point to do it approximately in 100%, not approximately, actually in 100% of my distal end radius cases is after the surgery, when I am closing my wound, I make it a point to always close the pronator quadratus airtight, watertight, as it might have been before I went in. And this is where the post-op X-rays. There is evidently some intra-articular malalignment, but I believe that is very less, might be less than 3 millimeters. Otherwise, the X-ray looks good. As I said, the plate is much above the watershed line, as you can see in the lateral view on the right. Now, we were pretty satisfied with the amount of fixation that we got, and the patient was also fine. We started the range of motion for the patient from the very next post-operative day. You can very well see on the videos the way he's tolerating the range of motion he's operating with us. And these were photos after a month of surgery. He was decently back to his normal life. You can see in the photos the flexion extension, the dorsiflexion, palmar flexion, everything is quite normal, quite close to normal. Even in this video, he's back to his pre-operative range of motion. And I even made him lift up the stool of my OPT to just demonstrate that his fracture is united, and it also gives a certain measure of confidence to the patient. Now, before the presentation of this case, I just called him up. I rang him up and I asked him to come to my office and I got these X-rays done. Now, these are 10 months post-op X-rays. On the left side, you can evidently see there is some intra-articular malalignment, but as I said, that is not very much, might be less than 3 millimeter. as they say, is the tolerable value. And on the lateral view also, the fracture looks quite well united. But as I said, the plate is above the watershed line, and these are his latest range of motion photos that I took just a couple of days back. He's his range of motion is pretty decent and very close to normal, or normal as I would say it. And this is a range of motion video. Now, what is an important point to stress upon in these in such very distal fractures is when I went up into the literature and I tried finding something. What could be done to prevent FPL injury, FPL rupture, or gritting of the FPL or FPL clunk in such patients whom we have to do distal plating? I could not get a very clear answer to what should actually be done. But I believe that the pronator quadratus, if you repair it, it acts as a pretty good buffer between the tendon and your plate. It goes from the distal fourth of the ulna to the distal fourth of the radius, and if you're repairing it properly, I don't think in majority of cases you would have any problem. Though in literature I could not find anything that says so. But in this patient, I did not have any problem, though I had explained early implant removal to him. But the patient has no clunk, the patient has no FPL problem, the patient has no gritting. He actually does not have anything that is